Let us get something straight.
Hey guys, welcome back. Hope I'm audible and visible. If so, say me a hi, hello. Hello Priya, hope you're doing good. Great. So I want two suggestions from you guys. Now I have moved to sitting and teaching posture, and the first two read with Robin series I was using a smart board. Um, you tell me which is more comfortable, and whatever is more comfortable, we'll do that. Fine. So how are you guys? How many of you read stem cells yesterday? Say a hi if you read stem cells yesterday. Did you guys read stem cells yesterday? Yes, hopefully. I got a couple of you guys send me notes of stem cells. I was very happy. So the ultimate motto of the series is to make sure everyone here is going to read Robbins, and you will tell entire junior here to read Robbins only. Fine. Hello Lion, good evening. Hello Sanika, hi. So now we are going to go with the second chapter, that's the cell engineering and cell adaptation chapter. I wanted to complete the entire intracellular accumulation. Good evening Rahul. So intracellular accumulation, I'm not sure about the page number in book, but here it shows 62 page number. I hope it's the same number. I'm good Rahul, hope you're good. Hello Arya. Fine. So what we're going to do is do the same thing. There's a Robbins Pathology book which I just put it here. Great Nayak. And I also have, as usual, I have taken a notes for you guys. So that also is available for me, right? And this notes will be shared in the Telegram group of PW after the class, fine? So let's go to intracellular accumulations. I've tried something a little bit of different thing. Just give me a second. I've tried something different. So I'm just marking in the Robbins book only. If you have your book with you, you also try to mark. So this is an intracellular accumulation, right? My first question of any topic, whatever you're going to read from now is why and what. So that gives me a definition. What is an intracellular accumulation? Hi Ankit. Now let's say I want you guys to answer. If you have a fever today, do you think you'll go to the doctor same day or you'll go after a couple of days? One day you take paracetamol and then you go for the second or third day, right? Let's assume a person has had some lump, some mass in any part of the body, right? So they won't go to the doctor immediately. They go after some time only, right? Hello Madrid fan. Okay, echo aa raha hai. Fine, I'll take care of that echo because I'm not in the studio today. That's why, right? So what will happen is I'll speak a little bit low maybe. So almost every time I don't go to the doctor immediately. I go after some time. When you go to the doctor after some time, always I might not see evidences of cell damage, right? What are the types of cell death? Can you guys comment? You must have heard about necrosis and apoptosis, right? So those are types of cell death. So always in a microscopy, I won't be able to see cell death. So these are all evidences of cell death, or these are all evidences of metabolic derangements which happens in the cell, right? It's one of the manifestation, that's all, right? It's one of the manifestations of a cell death I'm seeing in the microscope. One of the manifestations of a cellular damage, that's all. If you didn't take bath, I don't know whether you took bath or not, but if the smell comes, automatically a person will say, okay, this person didn't take bath today. Like that, intracellular accumulation are evidences of some derangement or some damage which has happened in the cell, which helps me to diagnose. That's what I've added in the notes as the first part. Various substances, it's an intracellular accumulation, right, that accumulate inside of a cell as an evidence. I might be using going forward E bar O as an abbreviation of evidence of, right? Evidence of cellular damage or metabolic derangement, right? That's a definition of intracellular accumulations. Many substances can accumulate. What we'll be reading today is lipid, in the next class protein glycogen, in the next class pigment, and then calcium, right? All of them we'll be learning here on the same RRR series, fine? So now something is accumulating. Let's always relate to real life. Let's assume your bank balance is increasing. What are the things do you think might result in an increased bank balance? Either you're earning more or you're spending less, right? So something is accumulating inside the cell. For that, I need some etiology. Only then things will accumulate inside the cell, right? Like, that's my second question. Again, when you go to the book, you will see here the reasons. Sorry. So when something accumulates in the cell, just give me a second. Okay. So how do they accumulate inside a cell? Those are concerned here. So there are four different possibilities. Either I can have an inadequate removal of a substance. There's some substance in my body which is having a metabolism. Am I right in saying that normally fat will be there in the body and fat is metabolized? You must have read about beta oxidation of fatty acids in your biochemistry. It's normally metabolized. So that's not being metabolized normally or inadequately removed, so something can accumulate. Or there's a failure to degrade metabolic substances. Yes, that also can lead to accumulation. It's not degrading properly. Again, I can have an accumulation. You can see an example. Failure to degrade lysosomal storage disorder. Can anyone online here comment on at least one lysosomal storage disorder? I'm sure you must have read about lysosomal storage disorder when you were in your biochemistry, right? Can you guys comment on one lysosomal storage disorder? Anyone, whatever comes to your mind. Or a glycogen storage disorder, lysosomal storage disorder. Anyone? Have you heard about Niemann-Pick's disease? It's a lysosomal storage disorder, right? Tay-Sachs, Niemann-Pick, all those are lysosomal storage disorder, right? Because of failure of the lysosome, yes, things can accumulate. Pompey's will come under glycogen storage disorder. Absolutely right? And I fine. Okay. So because of failure to degrade, yes, I can have some accumulation. Or else there should be an accumulation of a genetic or an acquired defect in folding of a protein. Let's assume, I try to give an example which you might already know. I'm having a defect in a folding of a protein. Have you guys heard about something called as chaperones in your biochemistry? Chaperones are something which will help in protein folding, right? So if the protein is not folded properly, for example, hemoglobin, if the hemoglobin is not folded properly, do you think they are functionally active? They are not active, right? They won't be active. So what happens is they keep on accumulating. At the same time, I cannot damage them, I cannot destroy them also, right? If it's a genetic defect, they accumulate. If it's not removed properly, they accumulate. Or there's a defect in the enzyme, they accumulate. Or next one. The fourth is an exogenous substances, right? The fourth is an exogenous substances. So when I have an exogenous substance, when I say exogenous, let's assume how many of you guys have tattoo here? Any one of you here having tattoo? I have a tattoo. Anyone? None of you have a tattoo? Can I say tattoo when I put it to a skin, it's an exogenous substance? Yes, it's an exogenous substance. Can my body metabolize a tattoo? Can my body digest a tattoo? It cannot digest a tattoo, right? When I'm going to inhale, right? When I'm going to inhale your coal, carbon, can your body digest your carbon? It cannot digest a carbon. So if something is coming from outside which my body cannot digest, it keeps on accumulating, right? So why and how an intracellular accumulation happens is, again, I have added that to the notes as well. So here, how? So either I have an inadequate removal, I am not removing it properly because it's been excessively produced, something of that sort, or I have an abnormal protein. Here if you want, you can add, it's a mutated protein. Some of the times mutated protein cannot be digested properly, it will accumulate, or is an exogenous inert material. Inert in the sense, it's not active, it's not reacting properly, my body cannot remove it. For example, the easiest example what I can give is a tattoo. Or I can have an abnormal metabolism. This is where all your storage disorders comes into play, right? So due to all these conditions, obviously things can accumulate in the cell. The first half of today's discussion is what is an intracellular accumulation and how it's happened. We know it's various substances as an evidence of cell damage, that's all, right? Hello code. Now here, the simple thing is why they are accumulating. Now let's go to the main part of today's discussion, which is lipid accumulation, right? We're going to read about lipid accumulation, okay? So lipids, there are multiple types of lipids. Before going to lipid accumulation, be it the book or the notes, I want you guys to comment what are the various types of lipid you know. You must have finished your biochemistry. What are the various types of lipid you know? Whatever comes to mind, you tell. Any type of lipid you know? Types of lipid? Cholesterol, great. Phospholipid, great. Anything else? Triglycerides, can I call LDL, HDL? All of them are types of lipid, right? So when I have a lipid accumulation, it's not just one type of lipid like glycolipids, sphingomyelin, everything is lipid components, right? So if you look at this, many things can accumulate, not just one. That's what happens first. So what all accumulates inside a cell? It can be a triglyceride, it can be a cholesterol or a cholesterol ester, it could be a phospholipid, or it could be any abnormal complexes of lipid like glycolipid, sphingolipid. All of them are protein complexes of lipid. Everything can accumulate inside a cell based on the situation. In the lipid accumulation which is there in the Robbins, they have not discussed everything. They have discussed only two parts. So when you write a 5-mark question, the first thing is lipid accumulation. What all substances can accumulate? It can be triglycerides, cholesterol esters, sphingomyelins, phospholipids, or any lipid complexes. Then types of lipid accumulation. In that types, Robbins discusses about two things and we'll look at both of them. One is steatosis or a fatty change, and the other guy here is, just give me a second, is your cholesterol and your cholesterol esters. These are two topics which we're going to discuss a bit in detail. Fine. Now first let's look at steatosis. So steatosis, this term steatosis is especially useful for whenever triglycerides accumulate. If cholesterol esters accumulate in a disease, I don't call it steatosis. It's cholesterol ester accumulation, right? So whenever you use term steatosis, which is equivalent to fatty change, which means it is abnormal accumulation of triglycerides within a parenchymal cell. This can come in a viva question. Fatty liver will not have cholesterols. If I call something as fatty liver, fatty change in the heart, or fatty change in any muscle, it is just your triglyceride accumulation, right? Second, where all it can accumulate. Which organ comes to your mind when you think of fat metabolism? Tell me any organ which comes to your mind when you think of fat metabolism. Any organ which comes to your mind when you think of fat metabolism.
I'm Detective William Murdoch.
Liver, right? So obviously liver is the first one which comes to most of us, right? So can I say in the peripheral, your skeletal muscle, cardiac muscle or striated muscle, again the fat is consumed as a source of energy. Is that statement right? That's also right to some extent, right? So liver is the most common example of fat accumulation or steatosis. We'll discuss about liver, though it's written in chapter 80. I'll cover it here as well because it's easy to structure your entire question. Fine. Now let's go to our notes. So what happens here is, like I said, anything can accumulate. Substances that can accumulate under lipid is triglycerides, cholesterol esters, or these. And the types of fatty change, what you're going to learn here is, one is steatosis, other one is cholesterol and its esters, right? Both of them are bigger headings. We'll go to it one by one. The first part here is steatosis or fatty change. It's just nothing but accumulation of triglycerides. I'm writing TGs for triglycerides, just an abbreviation here. Organs, liver is a common organ, like you guys said, but these are all extra pointers. If you miss liver, it's difficult for me. If you miss the other things, it's completely fine because there's no practical application of deposition of fat in heart or muscle or kidney. But yes, fatty liver is definitely important. As a doctor, you might see fatty liver when you go to your clinics as well. Fine. Now look at fatty liver. So you look at fatty liver, there are two common etiologies. One is NAFLD, the other one is alcohol. Can anyone tell me what do you understand by the term NAFLD? What do you understand by the term NAFLD? NAFLD stands for non-alcoholic fatty liver disease, and alcohol is obviously alcoholic fatty liver, right? So NAFLD is non-alcoholic fatty liver disease, right? Okay, perfect. Now just a random question to you guys, which you think is more common, alcoholic or non-alcoholic? We are just looking at fatty liver. In the first chapter of Robbins, not discussed here, but I just want to give a brief overlook of fatty liver as well here. Which you think is more common, alcoholic or non-alcoholic? Okay, Lion has gone for alcohol. Anyone else? Any day, non-alcoholic is more common than alcohol. If you look at Robbins, it will be written, I'll just show you what Robbins exactly writes. It will be written that in higher income nations, the most common significant fatty change is going to be alcohol abuse and non-alcoholic fatty liver disease. But for me, this one, non-alcoholic fatty liver accumulation, is a bigger problem than alcohol. I'll give you a brief scenario about it. Fine. Have you guys gone into PSM postings, or have they started teaching community medicine, preventive and social medicine in your colleges? They must have, right? Most of us don't like it, but preventive and social medicine is the best thing which can ever happen to medicine. I'll tell you the impact of epidemiology and preventive and social medicine in a real life of a medical career as well as the patient management. Fine. Let's take 100 people in our country, random 100 people. I can tell maybe maximum 10% of them might be alcoholics. consuming alcohol on a daily basis and damaging the liver, 10%. Let's take same 100% middle age group, 20 to 30 or 30 to 40 years. Tell me how many of them do you think they'll eat fast food, fried items, chips, burgers, pizzas? How many do you think will eat? Can I say more than 50 to 60% will eat on a daily basis? Yes. Now tell me which is a bigger burden, the fast food or the fried ones or alcohol, which is epidemiologically more common? Obviously the fried items, and that's more common, right? So any day this is a bigger concern. Non-alcoholic fatty liver disease is much more common than alcohol. The reason why I want youngsters to look at epidemiology is, now this chunk, non-alcoholic fatty liver, let's take 20-year-old person, everyone on an everyday basis consumes trans fat. So all these trans fats go to the liver, will deposit in the liver, will cause damage to the liver. But if it's alcohol, only 10% damages. So the volume is very high here. So which means, if my country is a good country, is there an age restriction for alcohol? Yes. Maybe in future we should have an age restriction for fatty food as well, because this is going to damage the liver and the life of a person much more significantly than alcohol, right? So we'll look at these two. Now these are the main two causes for me. Now let's see what is the pathogenesis. NAFLD is very simple. It's more and more consumption of trans fat. More fat I consume, my liver is not able to metabolize. That's where your inadequate removal comes. I'm not able to remove it completely, so automatically it deposits in the liver, because liver is a place where metabolism of fat happens, right? That's one half. Let's see how alcohol functions. Again, we'll go back to biochemistry. How do you think is alcohol metabolized? From alcohol gets converted to one more substance. What is that called as? Alcohol gets converted to aldehyde, right? Then aldehyde gets converted to, that's how the metabolism of alcohol works, right? So from alcohol to convert to aldehyde, I have an enzyme called as alcohol dehydrogenase. Tell me from your biochemistry, what do you think will be the cofactor for dehydrogenase? Perfect, acetaldehyde, right? Amazing. Have you heard about NAD and NADH, right? So when alcohol is being metabolized, when my body metabolizes alcohol, automatically the alcohol dehydrogenase functions. When the alcohol dehydrogenase functions, the NADH will become more in the body and NAD will be consumed, because this is consumed by the dehydrogenase enzyme. When the dehydrogenase enzyme consumes this, automatically the NAD-NADH ratio will alter. If there is more and more NADH, what happens is the synthesis of fat will increase, because all these are cofactors for enzymes. Oxidation will reduce and lipoprotein assembly will be abnormal, right? So if you have more synthesis of fat, less beta oxidation of fatty acid, can I say the fat will accumulate in the liver? Obviously it will accumulate, right? So that's how alcohol causes fatty liver. Because of the metabolism, I'm having more and more NADH. This is not there in Robbins. It was there in the previous edition of Robbins, but they have removed it. But this makes much more sense for me to understand, right? The major two causes, we know what is the pathogenesis. Just one more addition, few minor causes. I'm sure you must have read about protein energy malnutrition, right? Can you guys comment on any one disease for protein energy malnutrition? Whatever comes to your mind. Kwashiorkor marasmus, you must have seen for sure, Kwashiorkor and marasmus. Have you read that in patients with Kwashiorkor and marasmus, there will be wastage of muscles in the periphery? Yes. When the muscles are being lysed, will the fat from the muscle move, or the peripheral fat, will it move to the liver? It will definitely move to the liver, right? So in patients with PEM, that is protein energy malnutrition, there's a peripheral fat mobilization. This goes to the liver. So automatically it accumulates. It will definitely accumulate there, right? Cachexia, I'm just wasting of everything in the periphery. The lean body mass goes, everything goes, perfect, pot belly, amazing, right? There are few places where drug toxicity or few metabolic disorders of the liver. Whenever I'm taking a drug which is damaging my hepatocyte, it affects my mitochondria. I'm writing MT for mitochondria. Where does beta oxidation of fatty acid happens? Which organelle the beta oxidation and your metabolism of everything happens? Mitochondria, right? So if mitochondria of a cell is not there, what's going to happen? There'll be abnormal metabolism and it'll keep on accumulating. Reduced metabolism, which will result in accumulation. Okay. In your college, have they started pharmacology? Have they started NSAIDs and everything? Have they started teaching NSAIDs? How many of your colleges have started NSAID chapter? Autocoids. There in autocoids, if they have started or if you have read about autocoids, have you heard about a syndrome called as Reye's syndrome? No and yes. Okay. Have you heard about a syndrome called as, have you heard about this Reye's syndrome? If you're not heard, when you come to autocoids, when you come to NSAIDs, you will read about it. Reye's syndrome is due to aspirin. Aspirin is a non-steroidal anti-inflammatory drug. This aspirin will do the same thing. When children, especially when children take aspirin, just I am trying to correlate pathology and pharmacology, that's all. Remember this, when you come to your pharmacology, you read about Reye's syndrome, you can easily correlate. When children, especially when they take aspirin, in some of them, that aspirin can damage mitochondria. Once it damages mitochondria, automatically the fat metabolism will be altered and it keeps on accumulating, right? Perfect. So now we know about steatosis fatty liver. The second half of Robbins, that's the accumulation, has your cholesterol esters. There's one major difference between cholesterol esters and triglyceride accumulation, which I can easily look in the microscope and we can identify. Before going to this, I'll show you the microscopic image. Let's see if you're able to identify. This is your fatty liver, or I'll write triglycerides. Look at this empty spaces. I'll show you one more thing. And look at this empty space. This also is your empty space, but this is your cholesterol. What do you think is the difference? Are you able to appreciate the difference first? This emptiness versus this empty, is there a difference or not? How many of you feel there is a difference? If yes, say yes. If no, say no. Then we'll look at the right answer. Okay, current Kamran has gone for more emptiness. It's looking like a life, right, Kamran? There is a difference. Okay, great, amazing. So now, can I say that this empty space is more granular? It's more granular, right? If you look at this, can I say this empty is kind of completely uniform? It's completely washed away. And here, it's a little bit of more granularity. So whenever cholesterol esters or cholesterol accumulates, it will be very tiny granular appearance. And whenever triglycerides accumulate, it will be a wholesome accumulation, right? That's one tiny microscopic difference, which if at all, if it comes in a viva, you should be able to answer. Cholesterol esters always accumulate as tiny intracellular vacuoles. It will not completely replace, tiny vacuoles of accumulation will be there. All of these cholesterol esters accumulation are pathogenic only. I'm sure you must have read about atherosclerosis. Am I right in saying that one of the risk factors for atherosclerosis is your hyperlipidemia? Yes, hyperlipidemia, obviously hyperlipidemia. So what happens is, here the cholesterol esters, they accumulate in the intima of the blood vessel. It will accumulate in the intimal layer of the blood vessel. You must have read about the 3 layers of blood vessel, right? Tunica intima, tunica media, tunica adventitia. It accumulates in the intimal layer of blood vessel. And let's assume this is a vessel. And this is where all the cholesterol esters accumulate inside macrophages. I'm having a cell or a macrophage which is eating all the excess cholesterol. Is there a possibility the macrophage can rupture? Yes or no? Is there a possibility macrophage can rupture? It can rupture for sure, right? If it ruptures, the cholesterol kind of comes outside. If it ruptures, what happens is it forms crystals of cholesterol. So in an atherosclerosis, either you can see cholesterol inside a cell or you can see cholesterol as a form of crystals. Both of them can be seen. Again, once you go back to the Robbins, our goal is just to read the textbook, right? If you look at the Robbins, this is where atherosclerosis is. Here in the intimal layer of the large arteries and aorta, you will have foam cells, foamy appearance of foam cells. Foam cells are nothing but the macrophages which eat the cholesterol and they store there. And rarely, some of these fat Laden cells may rupture. Once it ruptures, it goes outside and they form crystals. Both of them, I'm going to say, it's due to cholesterol only. Foam cell can rupture or foam cell can retain as such. Fine, that's one. Okay, again, we'll go back to biochemistry. You're going to hate me at the end of the series because the amount of correlation what is there in the first year or the basic science to medicine is huge, right? Have you heard in biochemistry familial hypercholesterolemias? You have type 1, type 2, there is huge number of tables, right? LDL defect and everything. In those familial hypercholesterolemia table, whatever textbook you follow, have you heard about something called as xanthoma? Xanthoma, clinical appearances. Have you heard about xanthoma? You must have heard about xanthoma, right? I'm sure you must have heard about xanthoma. That's the second part here. So, second place where cholesterol esters can accumulate is xanthomas. So, xanthomas are accumulation seen in cholesterol defects or hereditary hyperlipidemias, right? Perfect. You can see in the eyelids. Amazing. You can see in the eyelids, skin of eyelids, and tendons. Here also I see cholesterol esters. I won't see your triglycerides. All these are cholesterol esters. Tubular xanthomas, eruptive xanthomas. Amazing. All these are familiar hypercholesterolemia defects, right? That's a place I'll have. So in xanthomas, also fat will be seen inside the macrophages. Here the rupture is a little bit unlikely, right? Now I'm going to give you one more meaning. Xanth. Whenever you see something as xanth, it's kind of calling something as yellow in color. What is the color of fat? Have you seen fat in naked eye? Have you seen fat? How many of you have seen fat? Say yes if you have seen fat. Not in microscopy. I don't know microscopy. I want your life. We'll relate life and medicine. None of you have seen fat? I'll sure do Samantha. Just give me a second. You must have seen fat. Have you seen ghee? You have seen ghee, butter, ghee, cheese. All of them are fat. Every fat is yellow in color. So when I call something as xanthoma, it is yellow in color. Bone marrow fat is yellow in color, right? Everything fat is yellow in color. Xanth means yellow in color. So deposition of fat in naked eye, it will have an yellowish appearance. Anything fat will be yellow in color. Please do remember. It is seen in familial conditions of hyperlipidemia, right? And I have one more disease called cholesterolosis. This is a form of an chronic cholecystitis. Okay. Cholecystitis is your gallbladder inflammation. Here also I can have deposition of fat in one of the layer. You must have learnt about the layers of your intestine. Lamina propria of gallbladder, you will have all the foam cells. Okay. Now the foam cells in the lamina propria of gallbladder, that's also a very important finding. Last but not the least, just for a genetic defect. What enzyme is defective in Niemann-Pick disease? What enzyme is defective in Niemann-Pick disease? Enzyme? Have you heard about sphingomyelinase? The Niemann-Pick disease, sphingomyelinase is defective. When sphingomyelinase is not there, sphingomyelin cannot be processed. It's myelin. It's again a part of fat, right? So here also you'll have accumulation. It accumulates throughout the body. Throughout the body it accumulates. Fine. Aishi, I will try to take whenever it's possible, till whatever it's possible. Fine. Okay. Robbins doesn't want to open. Fine. I just wanted to show you one thing. It's fine. Whenever it opens, we'll go back to it. So this is what is there in the fatty liver part. So I have both cholesterol and cholesterol esters accumulation, and also I have your steatosis or fatty liver accumulation, right? Now it's done with. So these are the theoretical part. So how we structured is, we know what is an intracellular accumulation and what are the ways by which it can accumulate. I'll answer Samantha, just give me a second. And lipid, many types of lipid can accumulate. Two of them we read in detail. Steatosis is one, and we read a little bit more in detail about fatty liver, NAFLD and alcoholic. We know why alcohol has fatty liver, because of altered NAD/NADH ratio, and why non-alcoholics is more of consumption, it accumulates, right? Other few causes, PM, peripheral fat comes inside, drugs of toxicity, mitochondria is lost. When mitochondria is lost, obviously the metabolism is going to be defective. Cholesterol esters, they are tiny vacuoles compared to triglycerides, it's a uniform thing. Foam cells are nothing but macrophages which consume or eat fat is called as foam cell. Seen, Samantha? So here I can have a foam cell accumulating or eating the fat and seen in the intimal layer, or it can rupture and form esters. Okay, and we have xanthomas. Xanthoma is yellowish appearance which can be seen in familial conditions in your eyes, in your tendon and multiple parts of the body. Fine. Cholesterolosis is also a place where fat accumulates. It's a form of chronic gallbladder inflammation. It's seen in the lamina propria and an enzyme deficiency here. Our goal here is diagnosis. You guys said that fat is yellow in color in gross. So what do you think will be the color in microscopy? If something has yellow color in gross, what do you think will be the color in microscopy? Good evening, Harshita. Microscopy also should have some color, right? But we just now saw, we compared two images. What is the color here? Why is it clear? Gross, I have a color, right? Let's assume this is a white color thing. You put in microscope, it should be white in color. It's black color. I put in microscope, it should be black in color, right? If fat is yellow in color, in naked eye, will it change in color in microscope? Will it change or it should not change? It should not change, right? But I'm having something as a clear appearance or clear spaces like all of you guys said, right? Now let's go here. The reason for this is normally the color of the fat in microscopy is clear. You guys are right. Do remember this. This is a thumb rule for me. It's washed away during processing of tissue. This will come in a viva, but it's not there in the Robbins. They have removed it. I don't know why they have removed it, but it is a very important viva question. Do remember it. So what happens is you must have seen microscopic slides. They are thick or thin. Very, very thin sections, right? Which means I have to cut my skin at 1 or 2 micron thickness. For that, I need a very hard skin. When it's soft, I cannot cut it. So for making a tissue hard, I process the tissue. During this processing, like some of you said, I use alcohol. So this alcohol used during processing washes away the fat. Let's assume there's a normal fat accumulating before processing, and once I process the tissue, the fat is being washed away, so it becomes a clear space. Now tell me, in this clear space, do you see fat or is just empty? Is there fat present here or it's completely empty? It's completely empty. Perfect. Right. Now, in a viva, teacher asks you, I wanted to see fat. I don't want microscopy. I wanted to see fat for sure. To see fat under microscope, should I process the tissue or should I not process the tissue? When do you think you can see fat? Nayak, I'll come to Sudan stain soon. I want to see fat. So to see fat in a microscope, should I process the tissue or should I not process the tissue? I should not process the tissue, right? Only when I don't process the tissue, fat will not be washed away and I can see fat as fat, right? This gives me 2 questions. These are perfect viva questions. The first thing is, fat can be seen only in only one section, which is called as frozen section. Do remember it. Next time, tomorrow when you go to college, please go to the pathology lab and ask them frozen section machine. Here I don't process. I put the tissue into a freezer, -20 or -30. It immediately becomes hard. I can easily cut. No processing. I can see fat as an yellow color, or I can see fat as a fat. It will not be empty. And only in a frozen section, since I see fat, I can use stains for fat. Oil Rideau and Sudan black cannot be done in a real section. This is a real section. If I do oil Rideau here, will I see fat? I won't, because empty. There's nothing there, right? So stains for fat, like you guys said, it's oil red O and Sudan black. There are multiple variations of Sudan black. Just remember Sudan black. These are both stains for fat and they also be seen only in frozen section. I can use these only in frozen section, and if I want to see fat, I can see them only in frozen section, right? This part is not there in Robbins under the fatty change, but it's very important. That's what will complete the answer, fine? So you have how to identify them. It'll be clear vacuoles and you have frozen section to see them and fat stains. This is what we initially saw. There's a biopsy of fatty liver, okay, and there's a biopsy of cholesterolosis. Both of the biopsies are there in your Robbins pathology. Have you guys seen fatty liver real slide? Have they showed you fatty liver in your lab? Have they? They have, they are not. They are not. Just give me a second. I'll see if I can pick up a slide of fatty liver. Do you want to see a real slide? I have a set of digital slides. I just want to see if I have a fatty liver slide. If I have a fatty liver slide, I'll definitely show you. Just give me a second. Okay. Can you guys stay with me for 2-3 more seconds? If possible, I'll show you a fatty liver slide. I hope I'll be able to see it. Just give me 2 to 3 seconds. If it's available, I will be. Just give me a second. I'll just remove this and I'll show you the slide. Just give me a second. Because fatty slides, digital slides are very good process to learn. You need not go into the microscope, you need not go into the lab. I report cases sitting from home. I'll show you how exactly we report. In the era of digitization, life is amazing. You guys are really lucky. You don't understand that you're lucky. That's the only problem with you guys. Just give me a second. Okay, so I'm not able to open it. Sorry for it. Give me a second. If possible, we'll see a slide of fatty liver. Amazing. Can you guys see my slide now? I just removed it. Okay, can you guys see my slide? Can you guys see my background? This is a real slide, a real pathological slide. Without a microscope, we have slides here. I hope it's visible. If it's visible, say me a hi or a hello. Now I can zoom this thing at any magnification I want. Can you appreciate the hepatic lobules? This is a liver slide, right? Let's zoom it. Let's zoom it. Let's zoom it. Let's zoom it. What are these? These are all. It's a fatty chain, right? So this is a normal hepatocyte. You can look at the normal hepatocyte. It's pink in color, completely pink in color. But when you go closely here, what's happening? It's having lots of empty vacuoles, right? It's a liver slide, a normal real life patient slide, which is a digitized slide and a digitized version. I'll show you one more structure. Just since you're still here, I'll show you one more structure. Tell me what structure this is. Can anyone tell me what structure this is? This entire one. I'm sure you can relate it. What structure is this part? This is a liver biopsy. What structure is this part? This part. No, this part is not fat. This is a liver biopsy. What structure? Perfect. That's a portal triad, right? Amazing. So you'll read whatever, you'll see whatever you read. What your brain knows, your eye sees. If your brain doesn't know, your eye doesn't see. This is not just for your slides, even for your patients. So read as much as possible. You'll definitely able to diagnose patients, right? You have again, I'll give you one more clue. You're going to tell me everything here. I have two lumen here. One lumen is collapsible, right? One lumen is non-collapsible, right? So which is artery? Kamran, I'll show you central vein also, because central vein will not be seen in portal triad, right? Which is artery? Collapsible one, non-collapsible one. Collapsible one is vein, non-collapsible one is artery, right? So this here is an artery. Can you even see RBCs inside the artery? This is an artery which is non-collapsible, and now this guy is in collapsed structure. Here also you can see RBC, that's a vein. With a portal vein, you have the hepatic artery, and can I say that here I am having a low cuboidal epithelium? What is this structure? That's a biliary radical, right? So you have a bile radical, you have an hepatic artery, and you have a portal vein. That's a classical portal triad. I'll show you central vein since you've asked for. Central vein sometimes might not be seen in an exact section. I'll have to search for a central vein. Yeah, this is a central vein, right? This is central vein where you don't see any accompanying triad. If it's just a collapsible vein in the center of a lobule, I call it a central vein, right? Okay, great. So we read about fatty liver, and also we saw a clear-cut slide of fatty liver as well, fine? Okay, I'll add, if you have any more queries, do let me know. If not, I'll call it a day, and I'll share the notes with the team and they'll put it on Telegram channel. I have almost every slide, whatever has been shown in your practicals. We'll learn one by one. Next time when we see an hemocytosis, I'll show you hemocytin. Whenever we read anthracosis, I'll show you anthracotic pigment in a real slide. and let's learn more together. Fine. Thank you. Bye bye. If there are no doubts, see you in the next class. Bye bye. Okay, amazing question, Nayak. I'll take that question and then we will take a leave. Fine. For answering that question, I need a little bit of space. You're right. You're perfectly right in asking why it is not hexagonal. Fine. Now, I'm having a tissue like this, a liver tissue. Is it possible the liver tissue, when I cut, it can be like this in a slanting position? Possible? So if I cut in a slanting position, will it be hexagonal or it will be different shape? It will be different shape, right? Because a transection, if I cut a finger like this, it will look round. If I cut a finger like this, it will look longitudinal. So it's based on the axis of the cut. It might be hexagonal, it might not be hexagonal. I'll show you perfect hexagonal cut also, but it will definitely be of different shape. Fine. Collapsible and non-collapsible. Just give me a second. I'll go back to the slide if possible. See here, who is that? Arya, look at this. This is a perfectly round one. If you look at this, it's not exactly round, right? It's kind of a weird shape. Here also it's kind of a weird shape. If it's perfectly round or oval, it's a non-collapsible structure. It's not collapsing, it's firm. If it's kind of collapsing, that's a collapsible structure. That's the difference between collapsible and non-collapsible. Fine. Okay, fine, great. So see you soon in the next class. Keep reading, and if you're taking notes from Intracellular Accumulation and Fatty Law, do share it with me. I'm going to be very happy, and I'll make sure that I will share the positive things of you reading Robbins. If you read Robbins, definitely I'm sure your friend also will learn to read Robbins. Fine. Bye bye. See you in the next class. Bye bye.